a little bit wood, so I didn't. Okay.
Okay. Welcome everybody to our afternoon session. We will start with our president of the society, Prof Ennker. Jürgen has personally some thousands done coronary bypass operations, and my first coronary bypass operation was also assisted by Jürgen in the early 90s in the Deutsches Herzchirurg Berlin in Roland Hetzer's clinic. And it's a pleasure to me that Jürgen has now given his lecture on coronary artery revascularization. Please, Jürgen.
Okay, dear Harald, dear Roland, thank you very much. Dear colleagues, the topic is coronary artery revascularization, 1986 to 2016. And if you look back, we had 30 years ago a completely different patient spectrum. There were a lot of contraindications: old age, poor ventricular function, diffuse disease, obesity, Jehovah's Witnesses. Those were the times when there was a surplus of patients, a deficit in cardiac surgical institutions, and a lot of surgeons only operated on patients who were adequate for operation, but not for the difficult cases. This was different in Hanover and later on in Berlin. Here, for example, you see a picture 30 years ago. Roland, he offered me the chance to come back to my native town of Berlin. Hans Borst, he was the one who put me into surgery. I was still in the back. You may know other people, other faces who became prominent later on. So we went to this very nice building, which was empty at that time, and Roland filled it with life, with patients and with young surgeons. So after 1 year, I had an invitation from the Cleveland Clinic where I went to in November '87. They wanted to organize a course on arterial revascularization, but nobody applied. And then they canceled it. I took the phone and called Floyd Loop, and I said I wanted to come. He said, yes, you can go. And so I went to Cleveland, saw arterial revascularization, and we brought it back to Berlin. This is a landmark paper from Loop and others from the Cleveland Clinic where they could demonstrate the difference between arterial and venous revascularization of the LAD. Another technique which was employed in these years was so-called T-graft, as described by Alfred Tector or others like Johnson from Milwaukee. Those were the techniques who facilitated the complete arterial, no-touch aortic revascularization. And instead of the right internal mammary artery, you also can use the radial as a second choice of arterial grafts. This is just a picture of a patient from me. Here you see the Lima and the T-graft and this anastomosis to the LAD. So if you look into the cross-section, you see that the Lima has a discontinuous internal elastic lamina and a relatively thinner media. And if you compare this to the radial artery, you see there is more risk for atherosclerosis than in the Lima. And this is also the reason why the radial artery for me is a second choice compared with the Rima. However, it's in use now in several hospitals and a second graft in order to avoid a higher incidence of mediastinitis following the employment of both internal mammarians. However, you have to keep in mind that the radial artery, which was described by Carpentier in 1973 for the first time, is very dependent on the degree of stenosis. You need a high degree of stenosis to have a long-term adequate patency rate, and if you have a degree of stenosis less than 70%, there's a high rate of occlusion. So you have to keep this in mind, that not every stenosis is adequate for radial artery. So another years later, there was another landmark paper from the Cleveland Clinic which clearly demonstrated the superiority of a bilateral internal thoracic artery over the years. This is true for survival compared to the single internal thoracic artery and venous grafts. There's a survival difference close to 10%. And of course, you have a much higher incidence of reoperation, which is increasing with the years, of course, in reflection of the higher occlusion rates of the vein grafts. So what we did at that time in our institution, which Roland enabled me to go there in Lahr, as early as 1998, we started transit time, Doppler flow measurements, and we were able to significantly reduce the incidence of postoperative ventricular fibrillation and enzymes and detected bypass malformations. If you want to see such a picture with such a flow and such a pressure index, you do not want to see things like this where you only have a flow of 2 milliliters, then you can correct. For example, this was a twisted venous bypass graft, and same situation corrected. This is a dramatic difference. The problem nowadays is which patients profit from coronary revascularization and which patients compare from intervention. It's not so long time ago that, for example, Brunzig said we estimate that only about 10 to 15% of candidates for bypass surgery have lesions suitable for this procedure. The surgeons, on the other hand, they say nearly everybody is able to be operated on. So the cardiologists have changed their view dramatically. I know there are cardiologists who say every coronary occlusion is fit for reintervention. And then we had a syntax study which defined different degrees of calcification. Here, for example, you have a 3-vessel disease on the left side, but you also have a 3-vessel disease on the right side, but they have different scores. And this is very important to have a look what happened afterwards. The cardiologists went into areas which were reserved for surgery in former days. And this also is reflected by a shrinking percentage of surgical procedures here in Germany compared to coronary intervention. New guidelines are defined by following the syntax study, and you see here it's the 3-vessel disease with a higher syntax score, or the left main disease with a syntax score higher than 32. Those are the areas where the surgery is in favor. However, those indications are also under fire. But are the physicians following these guidelines? Let's have a look. And if you look into the literature, you can see that up to 68% of the patients with a PCI and up to 59% of patients operated on, they are not informed as far as alternative therapies are concerned, either bypass or PCI. So, and probably 30% of the ad hoc PCI patients are probably suitable patients for bypass operation. This is the situation. Not everybody gets the procedure which is the best for him. And this is a remark of one of my referring professor of cardiology. He said, "I can do everything better than surgery." And they believe in it. They believe in it. So we have to stay against it, and we have to make our own improvements. And the question is, which technique should be employed? Let's have a look. I don't want to go into a lengthy discussion of OPCAP versus on-pump surgery. It's around 15% the off-pump method in Germany, and I heard it's pretty much the same in the United States, less than 20% at least. So we can only quote the European guidelines of myocardial revascularization of 2014. Complete off-pump procedures in the hands of highly trained teams appear to be associated with a reduced risk of early morbidity, such as stroke, wound and respiratory infections, as well as fewer transfusions and shorter hospital stay. This is one quotation. Another one, if you have a look here, what about off-pump coronary artery bypass is doing? It disproportionately benefits high-risk patients. So the sicker the patient, the better the results in off-pump surgery for him in comparison to on-pump surgery. If you look at the meta-analysis in randomized studies, there is, however, no significance as far as mortality is concerned. There's demonstrated no significance as far as myocardial infarction preoperatively is concerned. However, there is around 30% reduction of stroke. And if you have to keep in mind that the stroke rate in the syntax study is about 2.5%. If you're using a no-touch technique, total arterial, the surgeon cannot induce stroke. There's no heart-lung machine, there's no clamping of the aorta, and no cannulation. So if there is a stroke, those are patient factors. And just a final word, can you make stroke during cardiac surgery a never event? By Michael Mack. And one of the prerequisites is don't touch that aorta. And off-pump total arterial no-touch surgery is providing this step. So another advantage is the area of concomitant off-pump surgery and non-cardiovascular surgery. Here, for example, 150 patients underwent concomitant OPCAP and other combined cardiovascular disease for malignant and for benign diseases, simultaneous procedures. And the authors concluded concomitant off-pump and non-cardiovascular surgeries were not associated with increased mortality and postoperative mortalities when compared to isolated OPCAP. So just here's a patient who I received from Karlsruhe just 3 days ago. This is a 56-year-old patient. He received a 5-fold arterial bypass off-pump, no touch. These here are the anastomosis to the LID, diagonal, and then circumflex. And this is here posterior descending and the circumflex. And what he had also an ideal situation because he had a 48 millimeter diameter in the mid portion of his ascending aorta. It became normal close to the arch and was normal in the aorta region, in the root region. So what we did is 34 millimeter prosthesis, and that's the result. So simultaneously 5-fold total arterial off-pump and wrapping of the aorta, not a method from Hans Boss with a Lodenhose, but without off-pump. Yeah, that's a Lodenhose, yeah. Bavarian. Okay. What we also face are patients like this lady, born in 1923, 93 years old, and we still have to keep in mind that there are indications for us where the cardiologist cannot solve every problem. Those are osteostenosis, coronary occlusion, diffuse sclerosis, in-stent restenosis, coronary aneurysm, and coronary dissection. Those are the areas where surgical revascularization is there to stay. If you see a coronary angiogram like this, and the patient has problems here, this is a situation the cardiologist cannot solve, but the surgeon can do this. So another topic we have to talk about are quality performance measures. Here are outlined, for example, by the Society of Thoracic Surgeons. And there's a lot of areas to improve preoperative preparation of the patients. I always keep saying Boris Yeltsin, he was prepared 4 weeks before he went into operation, and then he survived. So this is not possible so easily in the German financial system, but there are a lot of parameters where we can improve. It's not only the surgical situation, but it's very important to keep those different steps in mind. The question is, where's the right hospital, where's the right surgeon? And there are numerous ways to find this. For example, the private hospital chains installed here Qualitätskliniken.de in Germany. You can look into the AQUA, or formerly BQS report, and there you can find information which are very easily handy in the state of New York or Pennsylvania or in Great Britain. For example, Bill Clinton, when he went to operation, he knew the mortality of Craig Smith from Columbia, and then he had the operation done. This is an advantage. We have Other, huh?
Craig did a bad job.
Yeah, that's a political sentence. But of course, we have other arguments against such transparency. However, myself, I think transparency is good. You have nothing to hide. I'm, as far as I know, the only one who's publishing his own results. Here are my personal results between 2009 and 2015, which can be seen in the internet. You see, I was able to have no dead person in some years, not every year. The rate of conversion is pretty low in experienced hands. We do OPCAP in reoperative cardiac surgery today, and the rate of complete arterial revascularization is 86.4%. So what I'm going just now, I invited the BQS people to certify this, and they are checking my records and my personal numbers, and I will have a certificate that those were reviewed by an external institution. This is also the first step in Germany. Nothing to hide. That's it. Okay. Okay. So there are so many ways to perform coronary revascularization. Here, for example, OPCAP in the awake patient. This was performed in Turkey, and if you look into India, I hear from ambulatory mid-cap, where people come to incision from the left side and go back home on the same day. There are other aspects right now. For example, the TCAP is only performed in high-paying Emirates. I don't know any other situation in some in the United States. Bonatti did this in Pennsylvania, as far as I know. So we have to improve, and we also can look into the future. We will see an expansion of knowledge. We will have a better patient preparation. We will see better better diagnostics, development of new drugs. We will see an intense quality control in cardiac surgery. It's just a few years ago that the difference between the best and the worst cardiac surgery in Germany was between 0.6 and 6%, which is a factor of 10 within Germany, not somewhere else. We see an improvement in surgical technology. Gender disparity will be overcome, and we will have an improved economic situation. So what is important for us, if you look here, disruptive strategies, there's a 37% chance of survival and only 6% for incremental strategies. And however, the best way to proceed is to go from disruptive strategy to a sustained innovation. So that's very important for us to stay ahead of the game. Thank you very much.
Thank you, Jürgen, for this excellent presentation.